Okay, so this gets into a little bit deeper on the managing the working capital and some of the components with that. To start with, I'm going to look again, if you remember seeing this chart, looking at accounts receivable. The first day you see a patient, and then on day 63, the insurance pays. In between that, day 3, in this case, we bill it, if you remember that. So I've added a little bit extra here on some information. And so when we look at that accounts receivable, when we see the patient to the patient billed, and so that's time to submission. So this time to submission, we may be getting authorization from the depending on the service what we're providing, or there may be cases where we don't have to have authorization. But in many cases, we'd need upfront authorization, and we're getting that, and then we were approved and we're able to bill, and so then we have our days in AR. So the whole purpose in cash management, to really manage your cash well, we want to minimize these days between the patient and seeing and the day that we're paid. As much as possible, we'd like to shrink that down and minimize it. That's going to maximize cash. And so sometimes we call this time to submission, in where I work, as unbillable revenue. So we've seen the client, and so it becomes a billable service, but we have not been able to bill the payer yet. So we call that unbillable. We have not billed our payer yet, our third-party payer yet. And so we track that amount of time and that amount of revenue that we haven't been able to recognize. We want to get that billed quickly and turned around quickly so that we can recognize it as revenue. Once it's billed, then we want to get it collected quickly as possible. So we want to minimize our days in AR. We're going to do some things to make sure that our claims go in what's called clean. We want to make sure our claims go in clean. We'll talk a little bit about that cycle. But if we're getting it in quickly and submitted it in quickly and have them in clean, hopefully we'll get paid right away. If for some reason there's something wrong with our claim, it can be rejected and denied, and we have to go back and figure out why and then go and resubmit it again. So we look at those reasons for rejection or being denied, and then we would resubmit it in again. What happens though is the clock is also ticking on their side. So on our side, it's ticking because of our cash. We want to manage our cash and maximize cash. On their side, on the payer side, the insurance payer, it's their clock is ticking for number of days that claim is outstanding. If that claim is outstanding for a long period of time, we can be denied payment just because it took us too long to resolve it. And so if the day is outstanding, we start getting into 120 days outstanding. The likelihood of us getting paid by the insurance goes down drastically. So we do want to get these paid by our 60 days and not have them out there for 120 days where we're waiting a long period of time and then have the insurance say, nope, sorry, the days that you've had this sitting out there have been too long and we're not going to pay you. On the wages, this is just still the same as before. Our wages are our biggest piece, usually, are paying our providers. And then we also will need to pay other vendors, supplies, and things like that. Here's what a source of working capital looks like, potentially. In this case, we have a strong amount financed with equity, meaning we have cash on hand. And so we have a portion here with cash on hand. But what we're ending up having to pay when it says this workload, what it really means is what we're paying out the door. So if we're paying out more out of the door, then what we're going to have to do is finance the difference with debt. And so you'll see here some debt financing. Like I've mentioned before, many companies have a revolving loan with their bank, like a 3% loan, and it's one where you can just charge it when you need it and pay it off. So if the timing for your payroll is such, you're paying your payroll this week and you're getting your cash in the door the following week, you would put it on that credit, you would finance it with debt, and then next week when you get the revenue in, you pay off that credit, that line of credit, and bring that down again. And the idea would be to minimize that as much as possible because you are paying interest, of course, when you debt finance. So it's ideal if you don't have any debt finance, if all of it is financed with equity. But if you can't, then you want to consider those various options. Managing our cash flow. So having the right amount of cash on hand. Um, Here's some different ways to consider about that as we look at more of the detail of that. We want to maximize and expedite cash inflows, like I mentioned, minimize AR, minimize that time to claim submission when we're getting our authorization. We want to minimize denials by doing claim scrubbing. And so when we scrub our claims, and this is something we'll talk a little bit about electronic systems, but they can help us to do that. We want to avoid timely filing issues. As I mentioned, if you start getting them out 120 days, the payers might come back and say, no, timely filing, we're not going to pay this. You want to work and resolve denials, so you want to work and resolve denials very quickly, and so you want to consider that. And we're also going to talk a little bit about charge capture assessment, and then electronic billing systems as tools to help you manage that cash inflow. And then we want to minimize and delay the cash outflows. And so we want to minimize how much we have to pay out as minimal as possible. And we want to look at the days and maximize out the days on what we pay out. And so when we look at maximizing those days out, one, you want to consider, can you pay them out 30 days? But then you also want to consider, are you going to get better depending on where you are financially? Do you need that cash right away? If you do, you can push those payments out and avoid paying interest on debt. But if you are in a cash basis where you don't have a debt, you may want to consider credit cards. You're paying them earlier, but you're getting cash back. So you're earning some money that way, maybe getting up to 2% back on all your cash purchases. And so I know we use that right now for our electronic system of managing our vendor payables. So our cash back from our credit cards pay for us to have more electronic management of our expense management system. So that's one way we do it. Also, you'd want to consider physician compensation plans. Physician compensation plans, looking at productivity models, are a way to manage that cash outflow. So if you have a physician who is seeing multiple clients and seeing many clients, so you're billing out a lot of revenue, then you're paying them more. And when they are not seeing many clients, if there's something where they're maybe can only see a few clients, then you're paying them based on that productivity. And so it helps you to manage a little bit better on the productivity and pay according to productivity. That can be very helpful in minimizing your expenses out the door and also maximizing that productivity. Here is an introduction. We're going to be talking in the next thing about revenue cycle management. This is just an introduction to it, starting getting you familiar with it. You're going to see here on the revenue cycle, the yellow, the start of a claim. You're going to see a client. You're going to schedule them up. You're going to determine their eligibility, all of that different information. You're giving your services. And so you'll see that little tick mark I have there to show the services are being provided. So then after that, you're going to submit the claim. And so there's a period of time before that claim is submitted, and then it's submitted and coded. We've talked a little bit about that, CPT codes, HCPCS codes, IDC-10 for diagnosis, that kind of thing. So we're going to submit our claims. And then we have claims management, payment posting. We're going to post our payments. We're going to look at our denials. We're going to look at, what codes are we using. We want to make sure that we're also maximizing revenue. If we have, a bundled rate, is that the rate that we should be using for that? A lot of times that bundled rates can be a little bit higher than if we have a broken down rate. It all depends. Or modifiers, if we miss putting our modifiers on and we have co-occurring conditions that we are providing services on, maybe we're not getting the full revenue that we should get. So we want to consider those kind of things. That's part of our claims management process. We also, if something was denied by the payer, we may appeal it. We may turn around and say, no, we're appealing that because of this. And so we're coming back. And then we have our AR management, which is just making sure that we're getting our collections done as quick as possible. That's part of that claims management as well. But that overall AR management and tracking, how many days does it take to get our AR in the door? What's typical? Where are we at with that? And then finally, we have what's called analytics. So financial analytics, and that's basically looking at the rest of the pieces overall. How are we doing overall? How is our payment posting? How long does it take to the time we are providing service to a client to when we're posting payment? Where are we coding? What are our payer mixes? What's the percentage that is we're having to write off? All those things are important in considering in our analytics on how we're doing with our services. All right, so part of that, we talked about a charge capture assessment. I said I would explain that a little better. Here is that. A charge capture assessment ensures that healthcare organizations aren't losing charges within the organization. The question being, are charges getting submitted to the payer? So when we're seeing the client, is it stopping there? Sometimes there could be a stop there and things are not getting submitted into the insurance. And so what it does is compare when we are seeing those patients and those documented medical records of seeing the patient, how does that compare to what we're billing? Are we billing on everybody that we've seen as a patient? And that would be a charge capture assessment. As if we're a large organization, if we're a real small organization, that might just be, I know all of that off the top of my head. If we're a large organization, it may be a whole analysis or a whole, some people have people dedicated basically to this for their workload. In that, now we can jump into electronic management systems. And so when we talk about electronic management systems, what are they? Well, there's 3 different ones that are often referred to. One, EBS, electronic billing system. So this is the billing system software side. So this specifically is talking about billing your third-party payers. This is where we're going to do our claim scrubbing. We're going to make sure that our claims are processed best, that we're going through a clearinghouse. The EBS is connecting to a clearinghouse system. They're going to house the information like the diagnosis code as well as your billing code and all that information. That's where that's going to be housed. An EMR, what is that? That electronic medical record, this is for the medical documentation of the healthcare services. So this is not the functionality of the billing, but the EMR, electronic medical record, is that record for the client. We've seen the client, here's their diagnosis, here's the treatment, here's the plan, here's the follow-up, here's any additional medications, all those different care things are going to be followed up in the electronic medical record. All right, so then we get into EHR. And some people really get confused by like all these different terms. What do they mean? So electronic health record. This is the integration of an EMR and an EBS. So we got the EBS component, which is our billing component, is typically in the same system as our EMR, our medical component. So we're typically doing it all one. And that's called an EHR. So whenever we're talking about the billing as well as the medical record, we're talking about electronic healthcare system, health record. And so an EHR. And that's a software that allows you to document both the services that you're providing to the client as well as the billing of that client. When you submit into the billing system, as we talked about, I mentioned a few things there. I threw out clearinghouse. That electronic billing system is going to bill to those third-party payers, typically through a clearinghouse. There you could bill directly, so you could manually bill, and you might manually type something in and bill it directly to a payer. If there is some specific payer paying you for this service. But in most cases, the insurance companies are all set up in clearinghouses through the whatever electronic health record system you're using. They have a specific clearinghouse or clearinghouses that they're using that transmit. And what that does is it stores all the data that you need for it's pulling information from the medical record side, and it's pulling information from the billing side. So it's giving the code, it's pulling the different codes that you need to bill, as well as the services performed and the diagnostic and all those different pieces, submitting it in and it does that as a claim batch file. And a claim batch file, what that does is it's consolidating multiple payers together. Multiple claims together. So we are going to send a batch file. We may be billing, we might have 20 people with Blue Cross Blue Shield, 15 people with Health Partners, another 10 people with United Healthcare. And so we have all these different payers that we're going to submit to. And so we have all those clients that we've seen them, each of those have records. So a claim batch file is going to pull all those together and say, okay, here's all our ones for United Healthcare, and submit it in through that clearinghouse into the United Healthcare, and submit them in to Blue Cross Blue Shield, and submit in those various ones. So they all go in as one. And then it also has what's called claim scrubbing, which I mentioned. And that's an internal process where the software reviews the claims to reduce errors before transmitting to the payer. So it looks at the basic things. Is everything included that needs to be included in order to get paid, in order for this to be paid? And then it's going to give you a transmission report. It's going to tell you, yep, everything was submitted. And so you'll get a transmission report as you submit those claims in a batch file. All right, so on the other side, so that's the revenue side, the cash side. On the other side, we talked about physician compensation plans. And today, most compensation plans, they might have a straight salary, or they're going to have some kind of, they might have a portion of straight salary, like 50% is salary and another 50% is bonus or incentive. Or they could have, like I mentioned, a compensation plan that's structured based on the number of clients they see. Often these ones are based on what's called relative value units. We've mentioned before, RVUs. There might be an RVU plan for the physician. And so depending on their productivity and the number of people they see, they might get paid a certain amount per RVU on seeing the clients. So those are ones that are done. Here you're going to see market data factor has to be always considered. This is always changing. These are three main ones where you do market data comparisons for physicians. Medical Group Management Association, MGMA is how people refer to that. American Medical Group Association, AMGA. And so these are various groups that you may use for compensation assessments. So often physician compensations, typically on an annual basis, are reviewed. Um, and there can always be pluses and minuses in the structure with it. It's not always a perfect picture. For instance, a neurosurgeon is paid typically very high, but their billings are also very high. And so the procedures that they're performing as a neurosurgeon are very high, and often they're working many hours. You might have psychiatrists, I've found in the past. Psychiatrists, sometimes the compensation is higher than what you can get when you bill for it. And so what you're able to pay a psychiatrist may have to be higher than what you receive from your payers, which creates a structure. And this is one of the reasons why it can often take 6 months to come and see a psychiatrist, because they have, a patient load such that in the number of psychiatrists that you can afford to have in the plan, because you might be subsidizing. Your plan could subsidize. So the neurosurgeons may be subsidizing the psychiatrists with the different compensation plans. So you might look at various pieces like that, or incentive structures to help manage the cash flow situation and payment. Physician payments, here we talk about physician payment models that are being developed and tested. Pay for performance, that's the RVU type method. Episodes of care, shared savings. And so shared savings are, some plans are, and some payers are paying a portion up front and later on paying a portion depending on meeting quality of care. And so if there's savings or some quality of care, there might be some bonuses that come back to the organization, which maybe then come back to the physicians as well. Key question in affordability of care is maintaining the huge investment of employing physicians. So this is, I talked about a little bit, the physician world and paying for physicians as the market continues to go up, becomes more and more competitive and more expensive, and the payments from payers are not growing at that same. In some cases, the payers and payments have decreased. And so this can result in looming physician shortages. We see this often, like I've used psychiatrists for an example, where their pay is typically higher than what you can get reimbursed for their hours of service. And so we may have a shortage of them being able to provide services. And so they may book out 6 months before somebody can see them and not have ability to have openings, that kind of thing, and may double pack some of their schedule so that if there's cancellations, that we don't lose on cancellations. There's also something called leakage, and so to be aware of what leakage is, if you're in a network situation where there's within a given network, and that given network may have a series of specialists within that group. And so they might have your family practice physician, and they see them and they say, oh, well, they have some specific eye issue and they need to see a specialist on eye, and they'll refer them. But there is sometimes where the referrals happen outside of the network. If there isn't a specialist for eye within that hospital or physician practice within that group, then they might need to refer out, or maybe the specific eye condition they have is not treatable within that network. And so that's what we call leakage, is when you have to go outside the network. And so there's always a concern if the client is going outside that network into other services. And so that is it for the end of the working capital, hopefully giving you some additional perspective on it.